So in order to answer the advanced questions in bladder trauma, which will be answered by a trauma personnel, either a mid-level, a trauma fellow, a urologist, urology resident, fellow, or trauma surgeon, you need to enter the site, and then you'll see the study come up. You go to site enrollment lists, and there should be patients that are pending. It will be very important to keep a database by the trauma registrar in conjunction with the trauma personnel and radiology, the three-tiered system of data entry for the AAST assigned de-identified number, the patient name, date of birth, medical record number, as well as the track number if your institution uses a de-identified trauma database. This will be essential in order to identify the correct scans that should be uploaded, as well as for trauma personnel to return to the patient's record and answer the advanced questions. An example of the de-identified database would be an Excel spreadsheet, like this sample, where the AAST MITC number, which was our first case, 15.2.1, is identified with the patient name, the date of birth, the medrec number, and the track number. Might also want to identify the date of injury or any other data that we would expect would be helpful in identifying the patient later on. So once you identify the patient's medical record number, then trauma personnel will go into edit the record. In this case, the registrar has answered all of the questions. Trauma personnel should confirm as much of this as is feasible. For instance, some of the questions are a little bit advanced, like here, bladder neck injury, urethral injury, or ureteral injury. And it may be good as the trauma personnel reviews the record to make sure these are accurate. The advanced questions start down here towards the end of the record, and they're marked advanced questions. So the first is the type of bladder injury. The choices can be extraperitoneal, intraperitoneal, both intraperitoneal and extraperitoneal, and a bladder contusion or superficial laceration. And this again reminds the trauma personnel that these patients do not qualify for the study. And then sometimes the type of bladder injury is unknown. For instance, a patient that was repaired at an outside facility and then transferred in, and records are not complete. So in this case, the patient had both intraperitoneal and extraperitoneal injuries. How was the diagnosis of bladder injury made? And so this patient had a CT cystogram due to hematuria in the emergency department. So CT trauma is not the correct answer, and that would be if patients underwent a CT scan with IV contrast, and then the Foley catheter was clamped and the bladder was allowed to passively fill. This isn't recommended imaging studies for bladder trauma. This patient had a dedicated CT cystogram when practitioners realized he had a pelvic fracture and hematuria, so it was diagnosed by this method. The other ways it could be diagnosed are found intraoperatively during exploration. In this case, we did get a CT cystogram, and we realized the injury was diagnosed based upon this. What were the initial reasons for repair? Intraperitoneal injury or a component of intraperitoneal injury. And this is the case here. The bladder injury clearly had an intraperitoneal component on cystogram, and this was one of the reasons that the patient was explored by general surgery. The bladder injury could also be discovered during laparotomy and repaired at the time of exploration. So for instance, in this case, you might have checked that this was found intraoperatively in the first 24 hours, and then that it was discovered during the laparotomy. Other reasons that this might have been repaired in the first 4 days is urine didn't drain well from the catheter, blood clots obstructed the urine, and so you might check both of these since both are possible. or it was repaired at the time of pelvic fixation due to concern over pelvic contamination of pelvic hardware with orthopedic procedures. Other choices are severity of extraperitoneal injury, large injury, bladder neck injury, other. And then concomitant rectal or bowel injury, and then under other, there's a descriptor for other reasons that the bladder might be repaired. In this case, the patient did have a bladder neck injury, but it was really the intraperitoneal component that caused them to get repaired immediately. If the patient was managed conservatively in the first 4 days, then did the patient fail this management? So in other words, was the patient repaired at 10 days because there was still extravasation of urine or urine was found to be fistulized? So in this case, the patient did not fail conservative management. He went to the operating room immediately. Now, if the patient had failed conservative management and was not operated on initially, and then they were operated on subsequently, what were the reasons that they underwent operative repair? This might be 2 weeks later, it might be day 5, day 7, something like that. It might be several months later. And so the reasons that you could choose are continued leakage of urine, continued blood in the urine, fevers and infection in the pelvis, fistula from the bladder, a bony spicule projecting into the bladder, orthopedic surgery on pelvic fracture and needed repair of bladder near orthopedic site. So say we were greater than 4 days and the orthopedic surgeons decided to do anterior fixation of the bladder and they wanted you to repair the bladder because of this, then you would check this site. Contamination of pelvic hardware, this would be, say, a patient that was brought back into the operating room and washed out and the pelvic hardware removed, something of that nature. And then you can check other and fill in an answer. So I'll say for this patient that they did not fail conservative management because they were operated on initially. Follow-up x-rays. Did the patient have any follow-up x-rays to make sure that the bladder had healed? We'll say in this case the patient did, and then we'll check which x-rays were done. This patient had a cystogram at approximately 2 weeks, and we'll make up a date. So he was injured March 1st and repaired March 2nd. So we'll say this was done March 27th, a few weeks later during follow-up. Was there persistent leak identified on follow-up x-rays or bladder imaging? So we'll go back now and say yes, as we had said prior. The patient had a cystogram, the date, March 27th, and was there persistent leak? If we had identified persistent leak, then it would ask, what are the additional things that were done? And so here we could answer other, and it would give a descriptor, or these are some of the choices that you could do. Continued catheter drainage for conservative management, and then it asks if additional x-rays were done for leak, and then it has the loop again of follow-up x-rays. So in his case, this was simple. There was no extravasation, and then we go on to the further questions. So when was the catheter removal? It was documented, and here was the date. And it was removed at the time of the cystogram, because there was no leak, and the patient followed up in the post-trauma clinic. Was there a suprapubic tube? And this would be related to patients with urethral injury, for instance, where a suprapubic tube is maintained. And we say yes. And that has a lot of implication because the catheter can be removed, but they're still undergoing drainage. Operative interventions. Did the bladder have to be repaired operatively, either immediately or subsequently? And he did have an immediate repair. And the first date of the repair was March 1st. March 2nd was the date of repair. And then it'll ask some details about the operative description. So, was a suprapubic tube left in? No. Was the bladder sewn with a single layer of suture? Bladder sewn with a double layer of suture or more? In this case, the patient had a bladder neck injury, which was extraperitoneal, and also had a medium-sized intraperitoneal injury. And the intraperitoneal injury was closed in 2 layers. So we'll say 2 layers was used, even though a single layer was used for the extraperitoneal injury. There was a pretty significant injury to the bladder neck, and an omental flap was mobilized to cover the bladder neck in between pelvic hardware that was subsequently placed. These are some other choices. And then you can put in the intraperitoneal injury, and it'll ask for the location. This injury occurred at the posterior dome, and it'll ask for the intraperitoneal size of the largest laceration, and the laceration was 3 centimeters. And we'll just leave that 3.0. Now we'll address the extraperitoneal injury. The extraperitoneal injury was on the left side and involved the anterior aspect of the bladder neck. So we'll say it's anterior. It was a single laceration, and it was on the left. And the size of the laceration was approximately 4 centimeters. There was a bladder neck injury. There was not a prostate injury, and there was no ureteral injury here. The patient did not require a second bladder repair. And so we'll answer that no additional bladder repairs were needed. Complications readmission. Was there a urinary tract related complication? So in this case, why don't we hypothesize that the patient was admitted with a UTI after his discharge? This occurred during readmission, not during the initial hospitalization, or it could be identified and managed as an outpatient. So we'll say it happened during readmission. The date of the complication, he was discharged on April 1st, we said. So say he came back in just a few days later. And this was also the date of the readmission related to this urinary tract infection. So we'll make that April 4th as well. What were the complications that he had? And we'll say that he had high fevers and pyelonephritis because a stent was left in place. Or a simple urinary tract infection would be without fevers. Pelvic abscess, and that would be something from a urinoma typically. And so, for instance, a patient might have a pelvic abscess that was related to urinoma, and you could check both boxes. Persistent leakage of urine or extravasation would also be checked in that scenario. Renal failure, soft tissue infection, these are all the possibilities we envisioned. And then, of course, there's other, where we can put in a descriptor for the reason for admission. So in his case, we'll say it was pyelonephritis. There was no evidence of leak, and he received IV antibiotics and was discharged. So actually, I messed this up because this was during the initial admission, and he did not have a UTI during his initial admission. It was during readmission that his UTI and pyelonephritis occurred. So we'll put it on the readmission. And then also these can be managed potentially as outpatient. Did the patient have any pelvic fracture complications? In this case, we'll say no. If we did answer yes, then we could check some potential categories of complications that might occur, and we can always put in other. In this case, he did not have any pelvic fracture complications. Management of complications, we'll say yes. And these are some of the management options that we envisioned. So this patient was admitted to the hospital, and he underwent prolonged IV antibiotics greater than a week due to his urosepsis and the hardware that was in place. These are some of the other options, and then of course you can check other and put in a descriptor. In the final portion of the advanced questions, the trauma personnel needs to just put in a short narrative of the patient's course. So here I've finished the short narrative, which can only be about 500 characters maximum. And I said the patient was admitted after a motor vehicle crash. He was ejected. I summarized his injuries very briefly. Said he was taken to the OR because a CT cystogram done upon transfer in the ER showed an intraperitoneal injury. Cystogram was normal post-operatively, and he was readmitted for pyelonephritis, which resolved. This is a very good box in order to write strange facts about the case or summarize the case because you feel that the entry is somewhat confusing. Like for instance, if you had checked other and put in a short descriptor, maybe you could expand upon that in this text box. So at the termination of this, it's very important to remember to hit pending, not complete. If you hit complete, you'll not be able to edit this any longer. We get a nice message here saying that our form was saved successfully. I'm not sure whether radiology can upload the scans even if the record is complete. It's very important to complete the record, and we'll find out that information when we find out the specifics of uploading radiologic scans. This ends the advanced questions in bladder injury.